Okay, so I want to remind you that we have what we finished last week was the mechanism for the skeletal muscle contraction. Just, a few main points. We have an influx of sodium via the voltage-gated sodium channels, right? And then as the cell reaches the action potential, calcium channels open, potassium channels open. Calcium flows in and maintains depolarization, creates that plateau over here. And potassium is responsible for repolarization. So repolarization does not occur until calcium channels are closed right here. Okay, and sodium channels at this point here, sodium channels, they are not just closed, they are inactivated. Okay, remember that? So you have opening of the channels, then during the plateau, sodium channels are closed / inactivated. Calcium and potassium channels are open, and then during repolarization, only potassium channels are open. Now, we have mentioned before, and yeah, I'm going to ask you, extensively ask you about the flow of ions, so you have to be very comfortable with it. Sodium flows in, calcium flows in, potassium flows out, things like that. Okay? Depolarization, repolarization, plateau, what is responsible for what? Now, in terms of muscle contraction, we have discussed that unlike skeletal muscle, cardiac muscle doesn't have to be stimulated by nerves. Remember we talked about it. When you can basically cut the heart out and it's still going to beat. So what sets, and well, think about it this way. So your heart beats rhythmically. Maintain this rhythmicity using CNS will require a lot of CNS resources spent just for the maintenance of rhythmicity. So it turns out that the heart maintains its own rhythmical contractions via the cells that we call pacemaker cells. So these cells are altered, changed cardiomyocytes. Okay? That makes sense. So it's muscle cells, cardiac muscle cells, but they're slightly different. And they have this weird looking potential over here. So you see that little incline in the beginning? The pacemaker potential? Pacemaker potential is formed by the leaky channels, sodium channels here. Okay? So sodium channels are open, sodium flows into the cell. Does that make sense? As it flows into the cell normally, cell depolarizes, then it reaches the threshold. As it reaches the threshold, calcium channels open. And when calcium channels open, calcium flows in, calcium is charged how? Positively, so you have depolarization, right? And then the cell reaches the action potential. At this point, calcium channels are closed and sodium channels are closed. Calcium channels not just closed, they are inactivated completely. So for some time they cannot open. Okay? Does that make sense? But potassium channels open here. And when potassium channels are open, potassium flows out of the cell and leads to repolarization. Does that make sense? Now here's the deal. When the cell is completely repolarized, when it reaches its resting membrane potential, at this moment sodium channels automatically open. And sodium starts to flow back into the cell. what happens to the membrane potential as sodium flows into the cell? It becomes more and more depolarized. So you have that pacemaker potential again. Does that make sense? Then pacemaker potential reaches the threshold, and you've got depolarization due to the calcium. So you can see that pacemaker cells, they have some differences compared to the regular muscle cells. First of all, the action potential, the depolarization, the actual depolarization, is due to which ion? Which ion? It's not sodium, it's calcium, right? Second, look at this. Remember we talked about contraction of cardiomyocytes. You have channels that have to be stimulated, have to be externally open. These channels, the sodium channels that are responsible for the pacemaker potential, they are open at the resting membrane potential. Does that make sense? So when cell is in the resting state, the sodium channels are open. So sodium automatically, quote unquote, flows into the cell. Of course, when the cell is completely depolarized, they close. But as it becomes repolarized, they open again. There is no inactivation involved. Does that make sense here? Does that make sense? Okay? So basically, you see that pacemaker potential is formed by sodium. Depolarization is due to the calcium. However, repolarization is basically the same potassium role. So these pacemaker cells, they set up the contraction rhythm, the contraction rate in the heart. And since we have figured out that cardiac contraction is all about electric potential, we approach the intrinsic conduction system of the heart. Those are the structures responsible for transmitting electrical impulse from atria to the ventricles. So let's work with anatomical position and their function. So the first node that sets up the rhythm is sinoatrial node, or SA. Sinoatrial node sets up the sinus rhythm. Does that make sense? Okay, we're good? Now, sinoatrial node has an inherent or intrinsic rate of 100 beats per minute, which means that if you take an isolated heart and you cut all nervous supply to the heart and somehow you make it beating, it's going to beat at the rate of 100 beats per minute. Well, usually maybe a little bit more than that, but ballpark. Are we clear about it? This is called, now we'll get to the sinus rhythm, okay? Essentially, since it has the highest inherent rate, it's going to be a pacemaker. In the healthy person, sinoatrial node is the one that controls the heart rate. Are we clear? Impulses from sinoatrial node, which is located in the right atrium, are sent to the atrioventricular node, or AV node. Right? AV node is at the junction, right? It's in the atrium, but it's right before the ventricle. Does that make sense? Now, AV node has several important features. The fibers that conduct the signal through the AV node much smaller, right? Does that make sense? So now imagine you have a lot of electrical signal that go through a lot of fibers, and then they end up stuck in the node with very few small fibers. It's like you try to channel a 6-lane highway into 2 lanes, which means that the signal will be delayed at the atrioventricular node. It's going to be delayed by about 0.1 second. Okay, so this, think about this. Let's talk about electricity. So when you have electrical signal generated in the atria, in the right atrium, in the SA node, that leads to the contraction of atria. Then signal reaches very fast, reaches AV node, and gets delayed there, which allows atria to contract before signal gets to the ventricles. Does that make sense? So your heart essentially, if this is atria and this is ventricle, contracts like this. Okay, atria first, ventricle second. Does that make sense? Now, AV node has its own intrinsic rate. Remember, all those nodes and fibers are essentially pacemaker cells. Now, AV node has inherent rate of 50 beats per minute, and this is called junctional rate. Okay, from the word junction. From AV node, the signal enters so-called AV bundle, a bunch of pacemaker cells, also sometimes called a bundle of His. Okay, sometimes you can run into this term in anatomical and anatomy physiology literature. So AV bundle is the only connection between the atria and ventricles, the only electrical connection. There are no gap junctions, 0 gap junctions that would connect atria and ventricles. Now, why it is so important? Why it is so important that there are no gap junctions, only AV bundle that connects atria and ventricles? Yes, but kind of moving on, like try to move a little bit farther. So if I ask you, why is it important that there are no gap junctions? In order to figure out, what do you have to imagine? What if there are gap junctions? What if there are gap junctions between the atria and the ventricles? What if? If there would be gap junctions when atria contract, what would happen practically instantly? If there are gap junctions between atria and ventricles, atrial depolarization and contraction will be followed almost immediately by ventricular contraction. You wouldn't have that pause, atria, ventricle, atria, ventricle. What you would have is something like this. Does that make sense? And you obviously do not need that. You need atria to contract first and ventricles to contract with a certain delay. Do I make sense here? Okay, so since AV bundle is the only structure that electrically connects atria and ventricles, it allows coordinated, delayed contraction of ventricles. Does that make sense? AV bundle branches, and each branch enters the ventricular wall. Obviously, the branch that gets to the left ventricular wall is bigger and more significant. Does that make sense? Because the wall is thicker. And these fibers that end up in the ventricular wall are called Purkinje fibers. Okay? Sometimes it is called by a very Mary? Sometimes it is called by a very fancy word, subendocardial conducting network. You need to know them as Purkinje fibers, basically. Okay? Now, the bundle of His, bundle branches, and Purkinje fibers all have inherent rate of 30 to 40 bits per minute. Are we clear? So the pathway is SA node to AV node to AV bundle to the bundle branches to the Purkinje fibers. And probably, seriously, like two most important physiological features here. Well, you have to understand, first of all, that this entire network is pacemaker cells, right? Another thing that I really want you to understand is that AV node, due to the smaller fibers, allows for the delay of a signal, and AV bundle is the only electrical connection between atria and ventricles. So there is a perfect delay in ventricular contraction in relation to the atrial contraction. There are no gap junctions between atria and ventricles. Inside of those chambers, oh yeah, there are plenty of them. But between them, none. We're good. Can we move on? Any questions about this? So, EKG, electrocardiogram. A little disclaimer, I'm not a doctor. Well, there's a joke about a science doctor, a PhD. When a friend of mine got his PhD, somebody, congratulated him, saying he's a very, very nice Icelandic guy, tongue-in-cheek kind of humor. So somebody said, "Hey, Friedrich, congratulations, you're a doctor now." I said, "Well, I'm not real doctor." So we're not real doctors, So I'm not by any means qualified to tell you about like 12 lead EKG or something like that. Basically, the idea is that you put electrodes on somebody's body and you measure the electrical impulses that go through the heart. Some of you you probably know more about EKG than I do. But my purpose here is to tell you the coordination of main elements of normal EKG and what it means in terms of the cardiac activity. We good? So this is a typical electrocardiogram. And the first thing that you're going to notice there is the P wave. P wave corresponds to the depolarization of the atria. Now, we have to go back to the muscle contraction and recall. So depolarization of the atrial muscle means what happens to the muscle. If muscle is depolarized, it is doing what? Contracting, right? So P wave corresponds to the atrial depolarization and start of atrial contraction. Does that make sense? We're good. And then you see this zigzag, which is QRS complex. So what happens? Here are two electrical activities. One is repolarization of atria, and another is depolarization of ventricles. Electrical impulses from atria being repolarized and ventricles being depolarized, they overlap and produce that zigzag, QRS complex. So far. And then you can see ventricles stay, polarized, depolarized for quite a while, okay? And then T wave represents ventricular repolarization. So let's take a look at the flow chart on the right, just to make sure that we get it just one more time, okay? Atria start to depolarize, that's P wave. They keep being depolarized, meaning atrial muscles are contracting. Speak up. And then you see the red color means they repolarizing. At the same time, the signal is in ventricular walls, in Purkinje fibers. And that signal starts ventricular depolarization. So you see these two events, they produce, by overlapping, they produce QRS complex. This time, the entire ventricular wall is depolarized. So that's sustained contraction. Does that make sense? And then during T wave, repolarization starts in the ventricles. And then when it's over, ventricles are repolarized and we start the new cycle. Does that make sense? Now there are few quite important, I was looking for the actual eraser, few intervals that we need to pay attention to, and they're pretty, kind of easy to figure out. So one is PR interval. This one is from depolarization of atria to beginning of ventricular depolarization. So what's the delay? Does that make sense? ST segment. ST segment reflects the time during which ventricular walls are depolarized completely. How long contraction lasts. And then QT interval. That's the whole period from the beginning to the end of depolarization. So if you would look at this, this would be QT interval. Does that make sense? Okay. And it's, kind of makes sense just from looking at the EKG. With that said, first we're going to talk about controls. Now that's quite exciting. What is the inherent rate of sinoatrial node? 100. Or like slightly more. Okay. What is your normal resting heart rate? 60, huh? Resting, no. If you have 100, that's something's wrong with you. 60, 80 is probably your, if you're unhealthy. Normally, it's going to be 60, 70. In very trained athletes, it can be as low as 40. You can actually slow down your heart. Next time you get physical checkup, I do it all the time just for fun. Especially if they show you, like if you see the pulsometer, just look at it. Don't try to hypnotize it. Slow down your breathing. Don't suffocate, just slow down your breathing. As you slow it down, you will see how your heart rate will decline. My personal record is to go from 60 to 55 in the matter of about 15 seconds. Okay, so like you can slow it down. Better yet, start training. Athletic training will decrease your resting heart rate normally. But let's say 60 to 70, okay? So what keeps it under the 100? It turns out your SA and AV nodes are under the control of the vagus nerve, which is shown here in blue. Okay? So vagus nerve is one of the cranial nerves that transmit parasympathetic signals from medulla oblongata. In medulla you have two centers. You have cardioacceleratory and cardioinhibitory. Cardioinhibitory, cardioacceleratory. Cardioinhibitory center will normally lower your heart rate. Cardioacceleratory center will increase it. I'm going to ask you a question. You are sitting, relaxing. Which branch of autonomic nervous system controls your heart rate at this point? When you're resting and digesting, which one? Parasympathetic. So your heart rate is, say, 70. And then you eventually decide to go and start exercising. So your heart rate will go, will go up. What will bring it up in the first place? What's going to happen to parasympathetic controls first? Come on. First thing that you need to do to increase your heart rate is to shut down parasympathetic, right? You shut down parasympathetic, your heart rate goes up. Then sympathetic system will kick in and it will elevate even more. Does that make sense? So your heart is, it has parasympathetic tone. It's under parasympathetic stimulation, constant parasympathetic stimulation. Does that make sense? So you have to be very comfortable with understanding what, like, parasympathetic stimulation, how will it change your heart rate? Slow it down. Sympathetic stimulation, increase. Are we clear about it? I'm going to give you a clinical case. You're a nurse. You are in the ICU. You have a patient with a heart transplant, freshly transplanted heart. So you walk into the patient's room to check for the, vitals. And you see that the patient's heart rate, patient is sleeping. Patient doesn't appear to seizing or running around, bouncing off the walls, no vomiting or respiratory arrest, nothing. Just patient is sleeping, maybe dozed a little bit by the drugs, but the heart rate is 110. Should you be concerned? After heart transplant, patient just received a new heart. Should you be concerned? No. Why? Think about this. What is the heart transplant? What happens? Tell me, what happens? So say, my heart is done, and I'm about to receive a heart transplant. What are they going to do with me first? I hope they will anesthetize me first. But properly secured patient does not require anesthesia, as you know. So they open my chest and they take my heart out. What do they cut? Everything. They cut everything, right, that runs to the heart. Okay. So what's going to happen to me next? Say again? new heart in, what they're going to do next? Not just drop it in, right? They're going to connect something. What they're going to connect? Oh no. Vagus, you cannot stitch nerves, huh? Veins and arteries, they're going to stitch it. Nerves? Nope. You can't do that. You cannot stitch the nerves back. So basically, there is vagectomy. Not complete vagectomy, but the branch that runs to the heart is gone. So is there any parasympathetic control over the heart? No. So this 110 is my new normal. Does that make sense? That's absolutely normal. I'm going to have a new normal resting heart rate because it's going to be SA node without any parasympathetic controls. Does that make sense? And am I going to have any sympathetic control over the heart? Nervous? No. Heart will still respond to hormones and chemical stimulation, but nervous? It's gone. Does that make sense? Actually, this example is taken from real life. But in the real life example, nurse was like panicking, saying, "This dude is dying, his heart rate is 120. And the doctor said, "No, he's fine. Just relax. Just vagus nerve is gone." So that's pretty telling, right? Now, basically, the recipient of the heart will have what we call a tachycardia. The heart rate above 100. Now you have to understand that it's not a disease. I don't know, like, I want us all to be on the same page. Like, cough is not a disease. We're not treating cough, you know, although we often actually do treat cough. So same tachycardia is not a disease. It is a sign of, it's a sign of something, you know. If I'm feverish, I'm going to have tachycardia. If I just exercise, I'm going to have tachycardia. When my son had his first asthma attack, and I checked his heart rate, it was 180. That's pretty badass tachycardia. Other than that, he was sleeping. I mean, tachycardia by itself, just elevated heart rate, okay? It can be caused by fairly normal reaction like excitement or blood loss. And we'll talk about why it happens, you know, or various drugs. Now, bradycardia is the slow heart rate. Parasympathetic stimulation, basically. Different sorts. Like, if you give someone acetylcholine, that's going to be overall parasympathetic stimulation altogether. Normally, bradycardia will be a result of extensive athletic training. In both endurance athletes and strength athletes. As far as I know, in really, really trained athletes, it can go, as I said, as low as 40 beats per minute. Although compared to whales, in whales, the resting heart rate is, I think, 5 beats per minute. But they have like a massive heart, 3 tons or something like that. It's enormous. Now, what are the pathologies of the conduction system? Well, as you can imagine, they are concerned with either blockage of the electrical signal going through or lack of synchronization. And first we're going to talk about blockage, and the first block is SA block. So remember that SA block, where is it located? Atria. When SA block, there's a electrical signal, okay, in the SA block, electrical impulse, What is depolarized? Atria, meaning atria contract. Now, how do we see it on EKG? P wave. When SA node is blocked, what are we going to miss on EKG? P wave. Now, are we going to get whatever's down the road? Yes. We're going to get whatever's down the road. We're going to get QRS. It's going to be slightly different because since atria are not depolarized, they're not going to get repolarized. Okay? But we're still going to have a heartbeat. One little difference. SA node is the pacemaker node. It normally sets up the heart rate. When it's dysfunctional, what takes over? AV. So AV sets up so-called junctional rhythm. 40 to 60 beats per minute. Can we live with this rhythm? Yes. Like poorly? It's not going to be really comfortable, but we can. So SA block is not yet really life-threatening. Okay? Does that make sense? And then AV block. If you think about this, AV block is like that only highway that goes from atria to ventricles, the only transition point for electrical impulse. And AV block means that the signal that goes through the AV node is partially or completely blocked. So if it's partially blocked, you're going to observe the dropped beat. So you have, look, you have P, QRS, T, P, QRS, T, P, QRS, T, P. Signal goes to the AV node, stopped. Okay? QRS and T don't exist. Beat drops. No ventricular depolarization, no ventricular contraction. That is what the beat is, right? That's what pushes the blood out. Okay? Basically, this is the second degree heart block. First degree is just extended PR interval, which means, you know, it's just it takes longer. So basically, let me put it this way. First degree heart block is the traffic jam. You're still going through, but not as fast. Second degree heart block is, what's it called in terms of the traffic jam? It's a standstill, but it's not a complete, like it's a traffic jam, but really bad one. Like you stand there and you miss work, you know. I don't know. I never ran into something like this here. Well, actually once, it was last winter, I was driving kids to the music classes and I was trying to get around the traffic jam on the junction between 271, 480, 422. And I decided to get off the highway to Miles Road from 480 to Miles. And that little strip of road, which is what, like 300 yards? Like after spending 15 minutes trying to get on the Miles Road, I called the place and said, look, I'm not I mean, I can come, but you will be all gone. I will be at your place at like 10 p.m. in the evening. You know, so that's pretty much like second degree. It's going to be all resolved eventually, but the beat is going to be dropped. Okay? And the third degree block is the complete absence of that transmission. Okay? So the impulse basically originates in the AV node or AV bundle. Okay? Not even AV node. It's actually bundle. AV bundle will take over. Does that make sense? In a complete block. So what you're going to end up with is SA not necessarily blocked, but AV is basically gone. No transmission through this. So AV bundle will take over, and its inherent rate is about 30-40, which is not enough. So just not enough pumping. The blood pressure is going to drop tremendously. So people with third degree AV block have to have a pacemaker. Does that make sense? Yes. That's a great question. Damage to the cells. Most likely as the result of myocardial infarction or lack of proper blood flow, just ischemia. Does that make sense? It doesn't have to be a full-blown infarction, but remember we discussed narrowing of the coronary blood vessels if there is an atheroma, coronary atherosclerosis, or endothelial dysfunctions, so coronary blood vessels start to constrict. Not enough blood come to the pacemaker cells, they do not have enough oxygen, they shut down the ATP production, and they cannot depolarize, repolarize, because remember, we talk about that flow of ions, okay? We never mention what maintains the concentration of ions across the membrane. What does? What maintains the sodium and potassium concentration? When sodium flows in, potassium flows out, eventually those concentrations are going to be what? Equal, right? Why they aren't equal? What moves them back? I don't want to say the key word. What moves the ions back? They flow this way. How do they get back? Pump. Sodium-potassium pump. Or calcium-hydrogen pump. Okay? All those ions are moved back by pumps, and they require ATP. It's a lot of work and a lot of energy. Yes? It just flows in. We'll get to the cardiac. Basically, atrial contraction is good, but not necessary. Does that make sense? But when heart is completely relaxed, I'm kind of jumping ahead, but when heart is completely relaxed, and that's a great question, heart is totally relaxed, in complete diastole. Blood flows freely in the ventricles. Atrial contraction is responsible for about 30% of blood. So atria, basically, when they contract, they squeeze a bit of a blood, like, okay, we're going to give some more. Does that make sense? When we'll get, I keep myself from going too much into cardiac cycles, so we'll just talk about it in 10 minutes. Okay? Ectopic focus and fibrillation. Ectopic focus. Oh, damn Latin. So focus is the point. Just some point. Topic, topos, place. Ec, EC, out of, external, okay? Basically, ectopic focus refers to the accidental pacemaker that is not in the SA node. Does that make sense? Okay? So, imagine the conduction system is like a band. Everybody is supposed to start playing at a certain time. I'm going to make a really bad joke. And in this band, you have a second drummer that is absolutely deaf and starts to drum, whenever he or she wants. Okay? So that completely throws everybody off. Does that make sense? That's ectopic focus. So you have a set of pacemaker cells that initiate the depolarization of muscles, not at the right time. Okay? So basically, if it's in the atrium, it generates premature atrial contraction. And if you can imagine that ectopic focus can be in the atrium, in the septum, so where AV bundle, AV node is, and in the ventricle. Does that make sense? So if it's in the atrium, you have a beat that is not at the right time. Does that make sense? This is called premature contraction. It can be stimulated by the stimulants. Sorry for my language. Coffee, cigarettes, you know, can do it. AV node, basically the same. Premature beat. The only difference is that, now think about this. You have a flow, you know, atria, septum, ventricle, right? So if the ectopic focus is in the atrium, then the electrical impulse that is premature will go like this. Now if ectopic focus is in the septum, especially in the AV node, then it'll go like this. So you're going to have a little bit of an unsynchronized atrial and ventricular contraction. And then ventricular, ectopic focus, premature ventricular contraction. It has an interesting feature. The T wave is an inverted polarity. Just flip back. Okay? So if you think about it, all three have the same causes. Any sort of stimulation, mostly sympathetic stimulation, like caffeine or nicotine. You may say, wait, nicotine, we'll talk about nicotine, okay? Sympathetic stimulation. But of course, premature ventricular contraction is more dangerous because it has higher risk to send the heart in the state of ventricular fibrillation. Again, you kind of have to imagine this, but think about it. You have a choir of cells. Choir of cells in atria and choir of cells in ventricles. And those choirs, the only thing that communicates, that connects those choirs is AV bundle. Does that make sense? So say we would be a choir, and the class that's in AP1 room would be a choir too. And there would be one person in this room, and we would have connection through that person. Do I make sense so far? Now, we all sing together. We all sing in the same rhythm. And then say this is ventricle. Okay, we are the ventricle. And then there's an ectopic focus, somebody who starts to sing out of rhythm. And it throws everybody's off because we refer to each other. As long as we are synchronized, the contraction of all cells in the ventricle is synchronized. When there's an ectopic focus which sends a weird signal, untimely signal, what can happen? You know how people sometimes when they sing and somebody starts to sing like out of tune or out of rhythm, the person can correct itself. That's fine. But sometimes it throws everybody's off. It's all completely unsynchronized. That's going to be ventricular fibrillation, and we'll get back to it. Okay? So fibrillation is basically when cells in the wall of a particular chamber start to contract in absolutely random way. So this is an example of atrial fibrillation. Now what's important to notice is that in the atrial fibrillation you still have ventricular contraction going on. Does that make sense? So in atrial fibrillation, does the heart pump? Yes. And it pumps basically enough to maintain, life. It's good. I mean, it's not perfect, but the person is not going to die. There are complications associated with it. For instance, in atrial fibrillation, the chance of formation of a clot in the heart is much higher. This clot may end up, so pretty much atrial fibrillation is associated with increased risk of a stroke. Does that make sense? So like if this is the heart, then it will be awfully hard for me. I'm not going to even attempt to maintain the ventricular rhythm and just show the fibrillation. Well, kind of works, okay? So this atrial fibrillation that I show you just increases the risk of the clot formation in the atrium. And this clot can easily pass, they're usually rather small, it can easily pass through all the valves, end up in the aorta, go into the smaller vessels, and if it ends up in the brain, that's a tough luck. That's stroke. If it ends up in the coronary artery, that's the myocardial infarction. Does that make sense? But atrial fibrillation isn't equivalent to death. Ventricular fibrillation is basically, I mean, it's not death, but it's very close to it. When cardiomyocytes in the ventricle start to contract randomly and haphazardly, heart stops pumping. Does that make sense? Like everybody starts to play their own tune, basically. That's it. So it becomes a cacophony. Electric shock or myocardial infarction may cause ectopic focus or may impair the transmission of electrical signal, and there you go. You have ventricular fibrillation. So how do we treat it? Defibrillator, the pads. Now, you're not setting the rhythm. When defibrillator, what it does, it's like imagine that you have like an orchestra that starts, everybody starts to play their own tune. If you ever played in an orchestra or in a band or sang in a choir, bringing everybody, so what is the quality that conductor has to have? Really loud voice, first and foremost, to pretty much yell, shut up. What defibrillator does, it shuts down, stops the heart. Completely stops it. If SA node can start over and set up the rhythm, then the heart starts beating. If it cannot set the rhythm, that's it. So basically, that electric shock doesn't set the rhythm. It tries to sort of erase the fibrillation. Do I make sense? A little factoid. The largest electric shock that was ever experienced by a human, after which the human being survived, was 150,000 volts. The electrical outlet in the United States, either 127 or 220 to 40. Electric chair is 2,500 volts. This person survived 150,000 shock. Which is pretty impressive. So with this, we're going to talk about cardiac cycle, and to the Lexi's question. So we're going to actually start with the answer to your question. Now, what we're going to talk about now, the only new thing that we're going to talk about is pressure relationships between the chambers. Other than that, the whole blood flow through the heart, the whole blood flow, the, what's the word? The electrical events, we talked about it. So, since it's a cycle, you can't really start it. That makes sense. Okay? But we have to pick the first step. So the first step is going to be a relaxation, cardiac relaxation, diastole. Here. All muscles of the heart are completely relaxed. Blood is freely flowing into the atria, and from the atria, it freely flows into the ventricles. Okay? Now look at this picture. Which valves are open? Tricuspid and mitral. Why are they open? What keeps them open? Pressure. So where pressure is higher? In the atria or in the ventricles during this particular step? Atria. Perfect. Now, which valves are closed? Pulmonary and aortic. What keeps them closed? Pressure, which is higher where? No. Always think about the direction of the flow. So these valves, they direct the flow from where to where? From ventricles to the great vessels. To the great vessels, right? So, in order for the blood to go into the great vessels, pressure should be higher in the ventricles. If pressure in the great vessels, like aorta or pulmonary trunk, is high, then this pressure will keep the valves closed. So there is no backflow. Does that make sense? So at this point, so we're going to talk about three anatomical structures: atria, ventricles, and great vessels. At this point, which structure has the lowest pressure? Ventricles. It's lower than in the atria and lower than in the great vessels. Are we clear about it? Awesome. So blood freely flows. Okay? And then, to your question, at the very end of at the beginning of systole, atria contract, okay? And that's when which node generates the signal? AV corresponds to, SA corresponds to which structure, which part of the EKG? T wave, okay? Atria start to contract and they send the remainder of the blood into the ventricles, okay? As they do that, as the blood gets into the ventricles and just gets there and gets there and gets there, what happens to the ventricular pressure? It rises, yes. As you can imagine, at some point, at the end, ventricles are not indefinitely huge. They can accommodate only so much blood. So, at the end of the diastole, at the maximum relaxation of the ventricles, that's ventricles, they're going to accommodate the maximum amount of blood. Do you agree with me? Do you see that? So that maximum amount of blood is called end diastolic volume, or EDV. Are we good? Okay. Now, look, atria, just push the blood into the ventricles. There's maximum amount of blood. And at this point, ventricles start to contract. What happens to the blood pressure in the ventricle? In the ventricle. They start to squeeze. Huh? What happens to the blood pressure inside the ventricle? It's not like... It increases. And at some point, the blood pressure in the ventricle will become higher than the blood pressure in the atrium. What's going to happen to the valves? Which one? Mitral, you can say AV, okay, but mitral and tricuspid. But think about this. At this point, pressure in the ventricle is higher than in the atrium, but still lower than in the great vessel. So AV valve is closed. What about semilunar? If the pressure in the ventricle is still lower than in the great vessel. Closed. Very good. Okay? So it is closed. Since both outlets are closed, the volume of the ventricle is actually, well, not the volume of the blood in the ventricle doesn't really change because blood doesn't go anywhere. Does that make sense? But the ventricle keeps squeezing. This part of the cardiac cycle, when ventricle contracts, but the volume of blood inside of the ventricle doesn't change, is called isovolumetric contraction phase. Does that make sense? And then, eventually, the blood pressure in the ventricle becomes higher than in the great vessel. What's going to happen to the valves? Which one? Why AV is still closed? Excellent, because pressure in atria is still lower. Okay? At this point, which chamber, which anatomical part has the highest pressure? When you just said semilunar open, AV still closed, it's ejection. Which part has the highest pressure? Ventricles. Ventricles have the highest pressure at this point. Does that make sense? Closed AV valves prevent the backflow, and open semilunar allow the blood to enter the great vessels. This is called ejection phase. So the blood enters aorta or pulmonary trunk. What happens to the pressure, blood pressure in those vessels? It rises, and when it becomes higher than ventricular, what's going to happen? Semilunar valves are going to close. AV still closed. Why? Because there's not enough pressure in atria yet. Does that make sense? And at this point, same volume of blood, both valves are closed. This is called isovolumetric relaxation. Does that make sense? And then eventually when ventricles completely relaxed, completely relaxed, the pressure in the ventricle is so low, then AV valves open and you start the whole thing again. Does that make sense? Now, when ventricles squeeze the blood out into the great vessels, do they squeeze themselves dry or not? They aren't dry. There's a little bit of blood left in each ventricle at the end of systole. And as you can guess, it's very creatively called end systolic volume. Does that make sense? That's your end systolic volume. And can you tell me how much blood is going to be pumped out of the heart with each contraction? I don't need numbers. How can you find out? Which two parameters will determine how much blood is going to be pumped out? Which two parameters, which two values will determine how much blood? What do you need to do with EDV and ESV? Amount of blood that is pumped out of the heart equals, what from what? You say it out loud. You subtract ESV from EDV. Okay, does that make sense? Before the ventricular contraction, you have EDV. At the end, you have ESV. The difference went into the circuit. Does that make sense? We good? When we're going to talk about this, we're going to enter soon into the Carl Stitz, Don Davis, Bill Armstrong. Those of you who take math know who I'm talking about. Bill Previtt's realm that is called math. So you will need to know two major mathematical operations, like really complicated mathematical operations: subtraction and multiplication. And what happens to the result when you change the numbers? We're going to use the words increase and decrease a lot. Okay? Now, this image shows you everything. So let's take a glance. The top line is EKG. This is heart sounds. Basically, now, valves, they make sound as they close. So-called lambda. This are the pressure relationships. The blue is ventricles, purple atria, green great vessels. In this case, they're looking at the left side, so left atrium, left ventricle, and aorta. Black, volume in the ventricle, volume of blood in the ventricle. Okay, so let's talk about what's going on. We will try to kind of move. Now imagine we have imaginary line. Okay, that moves from the left side of the picture to the right side. Can you do it with me? Good. So I'm going to draw, let me erase everything, and I'm going to start drawing lines, and you're going to tell me what happens at each line. What happens at this line? Heart is completely resting, relaxed. Okay, that's the diastole. Valves, AV is open, SL is closed because of what? The pressure in the aorta is much higher than pressure in the ventricle. Now AV is open because pressure in the atrium is higher, not much, but higher than the one in the ventricle. So blood freely flows into the ventricle. And then you have what? Depolarization of atria, meaning atria start to contract. Does that make sense? You can see it by the pressure. So atrial pressure increases, and ventricular, of course, increases because blood is pushed in. And then at this point, what happens? Why AV valves are closed? Why pressure is great in the ventricle? Not only this, not just a lot of blood. What else? Look at what I pointed here on top. Ventricle starts to depolarize, meaning it starts to contract. So QRS complex, right? Ventricle starts to contract, AV valves close, and pressure in the ventricle, and that's actually the sound, the first sound that you hear. And the pressure in the ventricle skyrockets. So at this point, you can see that the pressure in the ventricle, the blue line here, is between the aortic and atrial. So it's not as high as aortic, but it's higher than atrial. So that's your isovolumetric contraction. Does that make sense? At this point, you see the blue line goes above the green line. The blue line, no. I don't think I can. I'm kind of hesitant to enlarge it. I probably can, but I really don't want to because I can scrub everything. So, blue line is a little bit above the green line. Pressure in the ventricle is higher than in the aorta, so blood goes where? In the great vessels, in this case in the aorta. Okay, semilunar valve at this point is open. Okay, eventually it will become equalized. Okay, when it will become equalized, the aortic pressure will elevate. Think about this. Blood rushes into the aorta, and then as it tries, just because of the pressure, tries to re-enter the ventricle, the valve closes. So it creates this so-called dicrotic notch. Sort of a surge of the blood pressure in the aorta. Okay? So both valves are closed. Pressure in the ventricle decreases. And it decreases eventually below the pressure in the atrium, and at this point, what's going to happen? Relaxation of and opening of AV valve. Does that make sense? Okay? Does that make sense? Now, you can also see that not coincidentally, repolarization of ventricles coincides with the closure of the SL, semilunar valve. Because when ventricle starts to relax, the pressure in the ventricle drops, semilunar valve closes. And here you can see the volumes. So this is the volume that's going to be ejected. It's called stroke volume. And it's the difference between end diastolic and end systolic volume. Does that make sense? Now, for the purpose of, well, we're here, if you think we're here for the exams, well, that's partially true. But mostly, you're here to know these things. So you have to be able to take this picture and explain it. Just like take it and explain it to someone and see if they get it. Does that make sense? Let's take a break and then we'll get to the math. It's basically like calculus level.